We are live, sir.
Good morning, Pankaj sir.
Good morning, Ji. Good morning, Maninder. Good morning, Sham.
Good morning.
Good morning, Ajay जी तो travel कर रहे हैं गाड़ी में हैं.
Start going to DMA conference.
अच्छा अच्छा मैडम भी जा रही हैं हमारी, आप भी पहुंचोगे वहीं. ठीक है.
Good morning, respected faculty and dear delegates. Welcome to this fine Sunday morning. We have a session by Dr. Priyanka today. She is a microbiologist. I request Dr. Pankaj, President IIP Delhi, to say a few words.
Good morning, everybody, all the delegates and faculties. Pediatric ICU is a very, very important place where infections play a big havoc. All of us, say I'm a neonatal intensivist, but all of us intensivists, we are more scared of infections. Our hard work, our work is spoiled when the child gets an infection, and then we are in the jugglery to find out which one, how to do blood cultures, how to do PCRs, how to tackle that infection. So that is the very important aspect of pediatric intensive care which we are going to deal with today. So I welcome Dr. Maninder and Dr. Sham Meena, the people behind this whole program. It's a very intensive program which we are running, and I think this is the second last session. We will be finishing next week, and all these sessions are very, very important for all of us, including pediatric intensivist. So I welcome all the faculty. I can see Dr. Dhanya, Dr. Indra, Dr. Prerna, all senior people on which are there on the platform. So with these words, I'll request Dr. Sham to say a few words and then over to Maninder.
Hello, good morning to all, and warm welcome on behalf of Indian Academy of Pediatrics. Warm welcome to all our chairpersons or speakers, Dr. Neha, and thanks to Dr. Maninder and all team, especially Dr. Veena, to make this program successful. Thank you.
Hi. Good morning, everybody. So we have a very interesting talk today. It will be on blood culture and PCR and their interpretation. So first, I'll introduce the expert moderators with us. We have none other than Dr. Indra ma'am from Apollo Chennai. She's actually a leader, a good teacher, a mentor, and she has led many programs in pediatric ICU and emergency medicine. And now she's leading the program on solid organ transplant and BMT in southern part of India. And also she has started the fellowship program from the e-PICU chapter on liver transplant fellowship and BMT fellowship. So it's a pleasure to have you, ma'am, because we all face with these MDROs and these resistant organisms. So we require a clinician perspective also, because sometimes there's a fight between the ID and the intensivist. And now it's the appropriate time to introduce the ID person, who is the other side in the boxing ring. We have Dr. Dhanya. She's again a close friend. She's from Apollo Hospital, Navi Mumbai. And we have done many programs together. And I feel that she is the most humble pediatric infectious disease specialist, because we usually fight a lot. And it's a good fight. So a pleasure to have you here, Dhanya, because we require your perspectives also. And then we will have a fight between I can fight you. And then we have another expert speaker with us, Dr. Prerna. She is a microbiologist, and she did her fellowship when we were there at Medanta Hospital. And now she's leading the pediatric ID program at Chacha Nehru Bal Chikitsalaya, Delhi. So it's a pleasure to have you here, Prerna.
Thank you, sir.
And we will have many doubts and we'll bombard you with the questions. And we have a very special speaker, Dr. Neha. She is joined us today from Chennai, and she'll be traveling to Spain today only. So Neha again is we started together, I think so, our journey in clinical practice at Medanta. So I was in ICU and she was the ID champion there. And she's the first qualified infectious disease specialist of India. So it's a pleasure to have you here, Neha, with us, because there are many doubts and many clarifications that these students will have.
Thank
So
you so much, Dr. Maninder. It's a pleasure for me to be here as well. And I'm based in Gurugram, as everybody knows. Right now, I'm there in Chennai for a meeting. And it's really an honor and proud moment for me to be associated with you, as well as to have Dr. Prerna Khurana as an expert speaker. Dr. Prerna has done ID fellowship under me almost a decade back. So it's nostalgic and it's a proud moment for any teacher or mentor. Thank
And
you
ma'am,
so
I
much.
owe everything to that fellowship I did under you. Taught me so much, and I'm glad I could still continue doing that, what I liked.
Yeah, and I hope today's session is going to give clinical, practical points which will help the pediatricians in their clinical practice. So looking forward to even listening from you, Dr. Prerna,
Thank you, ma'am.
and lovely interaction with the moderators.
correct. So without wasting any time, Neha, should I start the video?
Yes, yes, please do. Yeah.
Yeah. Thank you. So, uh, 1 second. You have to tell me if the voice is there and it's full screen.
Warm greetings to all of you. I'm grateful to Dr. Maninder for inviting me for this webinar. And today I'm going to discuss regarding the blood cultures and PCR in the PICU, their interpretation as well as action. I'm Dr. Neha Gupta, infectious diseases specialist from the first batch of infectious diseases specialists in India, with close to 2 decades of experience across various hospitals, and I'm founder of NG Swastha, which is our infectious diseases clinic in Gurugram. I'm also secretary of SIDS India. So I'm going to describe the importance of blood cultures as well as the PCR with the help of this patient. Now, this is a 20-year-old boy. However, the principles which I'm going to discuss remain the same even for the pediatric population. So this is a 20-year-old boy who had no comorbidities, and he's from Sethi, Madhya Pradesh. On 20th of October, he was admitted with us in the ICU. He was admitted in shock. He had an AKI with the creatinine going up till 4, hepatitis, melena. He was febrile. And on NORAD, he was maintaining his blood pressure, which was around 90 to 100 by 60, with tachycardia as well as tachypnea. He also had severe abdominal pain as well as tenderness on examination. His hemoglobin was 9.5. The TLC count showed leukocytosis, and there was a drop in the platelet count to 50,000. These were the LFT alterations. The serum LTH was 900. The CRP was very high. It was 391. The ferritin levels was close to 7,000, and the PCT was 7.75. Outside, he had received doxycycline for 2 days, was not responding much to this, and he had received 1 dose of ceftriaxone before starting from Satna, where he was admitted in the ICU, to Gurgaon with us. So when he arrived at around 4 o'clock a.m. In the emergency, after drawing the blood test, we empirically started on meropenem. Now the question here in front of us is, which of the following is the most impactful method for arriving at the diagnosis? Serology test, blood cultures, imaging including a CT scan abdomen or a PET CT, colonoscopy, none of the above.
Blood culture.
So I will discuss each of these subsequently. So the patient was admitted with us on 20th of October, and from the emergency, the serological tests were also sent, and this included a Vidal, IgM dengue, and IgM leptospira, which was positive. The Vidal test subsequently came out to be negative. The Wheel Felix, which was also sent from the emergency, was negative. The blood cultures were negative as well. The CT scan abdomen, which was done on the day of admission, showed ileocecal thickening along with multiple lymph nodes, and they were large and necrotic lymph nodes. Along with this, there was this pleural effusion as well as mild ascites, and discussion with the radiologist mentioned that this could be TB as well. Now, he was also having melena, so a sigmoidoscopy was done, which showed that there were multiple blood clots which were traversing up till the middle part of the transverse colon. The further colonoscopy was not attempted because the patient was not tolerating it at that time. And now the correct answer is actually the detailed history taking skill. Why? Because when we look at all these tests, these looks very confusing. And when this patient had come to us, this in fact was the PET-CT, which was also done because he had large lymph nodes, and this was the ileocecal thickening and hepatomegaly. And since there was pleural effusion as well as ascites, even the radiologist was thinking that could this be tuberculosis. But what has made the difference is a detailed history taking. Now, with this patient's father, who's actually my mamaji, he texted that his son is not well and he has been having fever for the last 5 days. They were initially thinking that this could be dengue fever because the WBC count was on the lower side, and he was also getting treatment from outside where he had received antibiotics, to which he was not responding. Now, with this history, we inquired further, and the history of fever, it's important to note what is the onset, duration, and the progression. So it was an acute onset fever. It was high-grade fever right on day 1 with 104. Subsequently, 2 days later, he started having diarrhea, which were 12 to 16 episodes, watery loose motion, suggestive of a small bowel diarrhea. And then he was admitted after 2 days in shock and AKI in Satna in Madhya Pradesh. Now, since there was this history of fever as well as diarrhea, we inquired further, and they said that he had gone to Banaras just a day prior and he had eaten a dish which was transported from Bangalore. So it was a chocolate fudge transported from Bangalore, and it's the same night he started saying that I've started feeling feverish, and the next morning he developed very high grade fever. Since this history actually changed the entire game. And that is why this quote from Sir William Osler is very important, that we must always listen to our patients. It's the patient who is telling us the diagnosis. Now, with this history, as well as the onset of fever, as well as diarrhea, our differential diagnosis included that this is most probably a GI infection related to the contaminated food consumption. So the possibilities include Staphylococcus aureus enterotoxin, Bacillus cereus, non-typhoidal salmonella, enterohemorrhagic E. coli, and the leptospirosis, but based on the incubation period, because it had started almost the same day, it is going in favor of Staph aureus, Bacillus cereus, or NTS. We normally think of Staphylococcus aureus enterotoxin or a Bacillus cereus enterotoxin. However, NTS is also one of the important causes of contaminated food related diarrhea, which can go to sepsis. And in fact, here the blood cultures may not be always positive. Bacteremia may happen in 5% of the cases, but it can lead to severe sepsis, AKI, hepatic dysfunction, leukopenia, thrombocytopenia. And this is the most compatible. In fact, he had eaten chocolate fudge, which is egg, and that has NTS infection very commonly associated. So the history of which food the patient has taken or eaten is very important. So based on this history, we had performed a BioFire GI panel the same day when he was admitted, and this detected the salmonella. The blood cultures were negative for this patient, so this is not Salmonella typhi, but a non-typhoidal salmonella. And he received meropenem, to which he responded. Now, since we also had the evidence based from the BioFire GI panel, which is a multiplex PCR, azithromycin was added to this. We thought that we could de-escalate down to ceftriaxone, so that's why we de-escalated down to ceftriaxone, although the blood cultures were negative. But on ceftriaxone, the patient started having fever again, and also there were bloody stools which were seen. So that's why the patient was switched back from ceftriaxone to meropenem, and azithromycin was continued. And within 7 days, the patient was discharged. He was on meropenem for 10 days. And now, based on our knowledge that this patient is having acute GI infection with septic shock, which is related to the non-typhoidal salmonella, we started this patient initially on IV TMP SMX, and subsequently he was shifted to oral. Why? Because there was also extensive GI ulceration which had happened, so that would have hampered the absorption. That's why initially IV for 3 days, and then subsequently TMP SMX was given for 10 days. So a total duration of almost 3 weeks of therapy was given for a complete healing as well as for prevention of any relapse. So this appropriate history-taking skill, along with the right interpretation of the multiplex PCR, the blood cultures which were negative in this patient, as well as the serological test are negative Vidal, as well as false positive dengue IgM and false positive leptospira IgM, along with this multidisciplinary management of involving the radiologist, the critical care specialist, as well as the gastroenterologist, has resulted in early diagnosis, early start of appropriate antibiotics. It also avoided colonoscopy because that could have resulted in perforation in an acute setting. However, it can be done, but may result in complications. Avoided the bone marrow as well because there was a suspicion of lymphoma. But since we already had the diagnosis of salmonella from the BioFire GI panel, it avoided all these invasive investigations and of course prevented complications. Had there been a little more delay, it might have resulted in perforation and a much more longer stay in the hospital, as well as all this would have resulted in a much higher healthcare cost. We also know that an infectious diseases involvement improves outcome in patients with severe infections, which includes all these syndromes, including septic shock, bone and joint infections, bacteremia, HIV-associated infections, endocarditis, and even complicated infections like this patient was presenting with fever, diarrhea, and shock. It's important when we draw the blood cultures that they should be drawn in the right volume. Timing really does not matter, it's the volume which matters. And when one bottle of blood culture is taken, in adults, we tend to take like 8 to 10 ml in one bottle of blood culture, but that will result in the isolation or the sensitivity will only be 10 to 15%. If we take one set, then the sensitivity of isolating the bacteria increases to 65%. And with 2 sets, it is almost 80%. And with 3 sets, it is 95%. So the same analogy also is aligned with the pediatric patients who are in the ICU. The volumes matter, and in fact, the blood culture has to be collected in the pediatric blood culture bottles, which are the green bottles. And usually in the adults, it is we collect 8 to 10 ml, whereas in the children, the volume is based on the weight of the child, and for patients who are weighing less than 40 kgs, no more than 1% of the patient's total blood volume, which is 70 ml per kg, needs to be collected. So at least in a patient who's 10 kg, so it will be 1% of the 70 ml per kg, that is 700 ml. So it will be 7 ml for a 10 kg patient, and 28 ml for a 40 kg patient should be collected for improving the chances of isolation of the bacteria. Now there are, besides the GI panel, there are several molecular assays which are well established based on the syndrome. So identifying the clinical syndrome is important, and then we can perform the various assays, which includes for a CNS infection, a Filmeri meningitis encephalitis panel. At the same time, this panel detects 14 most common pathogens which are responsible for the community-acquired meningitis, encephalitis, including viruses, bacteria, as well as the yeast. However, we must remember that it does not detect TB, which is very common in our country, rickettsiosis, Acinetobacter, which is a nosocomial pathogen, Enterococcus, cons, Japanese encephalitis, KFT, Nipah, as well as Cryptococcus. We also have the BCID panel, which can detect the 24 pathogens and these 24 bacterial pathogens within 1 hour of the positive blood culture. Besides this, it can also detect the Candida species as well as the resistant mechanisms, including the MEC-A, VAN-A, VAN-B, as well as the 5 major carbapinamases. However, we must remember that bugs like Stenotrophomonas will not be detected by the BCID panel. So Stenotrophomonas, Burkholderia, Elizabeth may not be detected. We also have the BCID panel can detect Stenotrophomonas. However, it does not detect Burkholderia. So we have the URTI panel, which is also we have a URTI as well as the LRTI panel, and this can detect the various common pathogens which are responsible for the upper respiratory tract as well as for the lower respiratory tract infections. And as we have recently in this case described the importance of the Filmeri gastrointestinal panel, which can detect the common pathogens, including parasites, bacteria, as well as the viruses. Now, it's important to know when to perform the molecular PCRs when there is a positive culture. So, traditionally, when we take the blood culture when we take the specimen and it grows in the culture, it may take around 48 to 72 hours to finally know that which antibiotic is going to work. However, there are certain tests which can be performed right when it beeps or becomes positive in the blood culture. And this is a table which helps us in analyzing the various diagnostic assays which can help us in detecting the carbapinamases like the NDM, OXA48, and can help the clinicians to choose the antibiotics for a patient who is in sepsis. So we have Expert Carba-R, which is a real-time multiplex PCR, and this can be performed from the positive culture plate or also from the positive blood culture bottle. So as soon as it beeps, so maybe even the first 24 hours, if the blood culture is positive, the Expert Carba-R can be performed, which is a turnaround time of 50 minutes. It can detect the 5 major carbapinamases, including the NDM, OXA48, or the co-production, and has a very good specificity of around 100%. It is around 3,500 to 5K, depending from institute to institute. Then we have the Filmeri BCID panel, which is a real-time multiplex PCR, and it detects the genes, the 5 major pathogens, along with the organism ID can also be detected. So whether it's a Enterobacteriaceae or it's a Acinetobacter, Pseudomonas that can be detected from the BCID panel, and it can be done directly from the blood culture bottle, and the results are available to us within 1 hour. However, the limitation is the cost. We also have now certain multiplex lateral flow assays. These are immunochromatographic detection assays, which are non-nucleic acid based. That means it does not detect the gene. It can be performed from the positive growth plate, so not from the culture bottle. So it may take another additional 24 hours for the organism to grow on the culture plate. The advantage is that it can tell us just within 15 minutes the major carbapenemases. It has a very good sensitivity and specificity. The sensitivity may range somewhere around 90 to 95%. Now, based on the mechanism of resistance, whether it's OXA48, NDM, we can choose our antibiotics. So if it is OXA48, then we can choose ceftazidime avibactam. However, if it is an NDM producer, then or an NDM with OXA48, then our treatment options are limited. And here we must perform synergy testing between ceftazidime avibactam and aztreonam through a broth microdilution method and not a disc diffusion method, because BMD is much more specific, whereas the disc diffusion may miss out, may give false negative synergy in close to 50 to 55% of the cases. If it is NDM, then we also have this aztreonam avibactam, which is available with us, and that can be used for the treatment of the NDM producing Enterobacteriaceae. Aztreonam avibactam may not really work for Pseudomonas, because with Pseudomonas, besides NDM, there are additional mechanism of resistance which may compromise the activity of the aztreonam avibactam. So how does this aztreonam avibactam work? Since it's a new molecule, it's important to understand the mechanism of action. Now we have the aztreonam, which is monobactam. It is stable to the NDMs. However, it gets hydrolyzed by the ESBL as well as the AMCs, which are present in the periplasmic space of the gram negatives. So what avibactam does is it protects the aztreonam against the beta-lactamases, ESBLs and the AMCBLs, which are present in the periplasmic space, and thereby allows the aztreonam to cross the periplasmic space and bind to the PPP3, which is essential penicillin binding protein of the gram negatives present in the inner membrane. And this then inhibits the synthesis of the peptidoglycan layer, resulting in the bacterial cell lysis. So this is the mechanism of action, and it will work against the metallo-beta-lactamase producing Enterobacteriaceae, especially the Klebsiella pneumoniae, as well as E. coli. However, it may not have activity if there is PPP3 inserts for the E. coli. It has no activity against Acinetobacter baumannii, Listeria, gram positives, as well as anaerobes. So this we must keep in mind and give additional coverage based on the site of infection. And if a patient is on aztreonam avibactam and is having sepsis, then we must keep that there is a possibility of Acinetobacter baumannii as a superadded or a secondary infection. So the suggested workflow for a patient who is in sepsis, in the PICU, and is showing gram-negative bacilli is that identify based on the gram stain or with the availability of Malditov, the identification of the bacteria, and we can perform the assays, which includes the expert carbar, maybe BCID panel, or even the lateral flow assays. If the carbapenemase is not detected, then careful de-escalation of the antibiotic can be done. However, if it is carbapenem resistant, then based on the mechanism of resistance, we can choose the antibiotics. Like for OXA48, it is ceftazidime avibactam. For OXA48 with NDM or NDM, it is going to be aztreonam avibactam or Cazavi with aztreonam. or a polymyxin B combination therapy based on the various factors. And it's important that we should definitely involve a multidisciplinary collaboration, including infectious diseases consultation, send right investigations, including the blood cultures, which should be done prior to starting the antibiotics, which in fact is a very quick and cost-effective solution for patients who are arriving with fever as well as sepsis. It is all about the right test, the right patient, as done at the right time. And more importantly, we must always emphasize on infection control, because all these antibiotics, they're hanging by a thin thread, which may snap any moment. And it's very important that we use them judiciously and with responsibility. And this is our initiative for creating awareness regarding infectious diseases in the community.
So we had a very snapshot type of lecture by Dr. Neha. So before we go on for the question and answer and for discussing these slides, I'll request Dr. Prerna to present her presentation first, and then we'll take the Q&A and the questions in the last.
Yes, sir. I hope I'm audible. So good morning, everyone. And first of all, I'd like to thank the organizers for giving me this opportunity. So mine is a very short and crisp, mostly regarding the aspects of blood culture and PCR. So I am Dr. Prerna. I am AP in Chacha Nehru Bal Chikitsalaya in the Department of Microbiology and Infection Control. So I will be dividing my talk in the following. I'll be talking about the principles and workflow of blood cultures and recognizing the limitations and challenges of when you talk about blood cultures and PCR in the PICU, and learn about the basic PCR that are available for rapid pathogen detection and comparing their turnaround time, accuracy, and the clinical impact, and how to integrate both methods for the improved antimicrobial stewardship. So just for an introduction, we all know how important sepsis is in the pediatric critical care. So early diagnosis of sepsis is very important to prevent morbidity and mortality, as delayed antimicrobial therapy is associated with high morbidity and mortality. And because of that, we need accurate and rapid pathogen identification. Coming to blood culture. So what is a blood culture? So what you see here are blood culture bottles available. So earlier we used to have a very conventional blood culture methods. You take the blood in a bottle, which is media is made in-house, and then you incubate it, and then you culture it. It used to be a long process. The sensitivity was much lower. Now these automated blood cultures bottle that are available now, Bactialert, Bactec. So these have really improved the sensitivity of blood cultures, because these bottles, the media in these bottles, have inbuilt carbapenemase inhibitor, like carbapenimases. So they actually lyse the antibiotics which were priorly taken by the patient. So the sensitivity has really improved with the coming of the automated blood culture systems. So blood culture is the gold standard for diagnosing bloodstream infections, and it involves the growth of microorganisms from blood samples. It detects bacteria and most of the yeast, like all the Candida species can be identified most of the times. And because there is growth on the plate, so we can even do antimicrobial susceptibility testing. Now, when do we take a blood culture? When we have a suspected sepsis patient, when we have a patient with fever and we can't find a focus, when the patient's clinical condition is deteriorating, for immunocompromised children, and when we are suspecting a central line associated bloodstream infection. So coming to the sampling techniques, so as we all know, strict aseptic techniques have to be followed. The site has to be prepared properly. This is a very, very important step to prevent the growth of commensal flora. So it has to be cleaned very properly. You clean the area with 70% alcohol centrifugally from inside to outside, so that the flora of the other part of the skin, which is not cleaned, does not contaminate the area. Then you let it dry properly. Then you clean it with iodine in the same fashion, inside to outside. Then you let that iodine dry again, and you again clean it with 70% alcohol. So these three, it might sound like a longer process, but it is actually very important. And then, as ma'am, Dr. Neha also said, we have to use appropriate blood culture bottles. Taking samples of pediatric patients in an adult bottle will not help, as the volume will really affect the growth of organisms. And we have to avoid drawing from intravenous lines. So the optimal blood volume that is taken is, as Dr. Neha has already said, according to weight base. So neonates, we can take 1 to 2 ml per bottle. For infants, approximately 2 to 3 ml per bottle has to be taken. And for older children, 5 to 10 ml per bottle can be taken. And as ma'am has already said, 2 bottles will help in better recovery of the organisms. Underfilling will lead to false negatives, as you know, the load will be less as compared to the media in the bottle. So it will actually result in false negatives. So this is how we do in a microbiology laboratory. Okay, you inoculate the sample, you give us the bottle with blood sample in it, and we inoculate into automated blood culture systems. So the photos that you see are the automated blood culture systems. These are the BactiAlert and Virtuo. So there are 2-3 models of good automated workflow system. Most of the hospitals here have the same models. So Bactec, BactiAlert. Once after a few hours of incubation, if the bottle is positive, it will give us a positive signal. So we take out that bottle, we make a gram stain of the bottle and subculture it. So preliminary report, we can tell by the gram stain itself that whether it's a gram positive cocci or a gram negative bacilli. And the clinicians really appreciate it because you can start the treatment or modify the treatment accordingly. And we do a subculture on the culture media plates. So that culture media plates, the organism will take another 18 hours at least to grow. They need an overnight incubation, 18 hours to 24 hours to grow. And when the growth we get on the plates, we identify that using automated identification systems like Vitek2 and Malditov MS. We have those automated identification systems. We identify that, and according to the identification, we give the antimicrobial susceptibility testing, again via the automated systems, or disk diffusion. But automated systems give us gives us accurate MICs also, so they are always preferred. And then the final report is communicated to the clinicians. And in between also, we keep telling them, okay, gram stain has shown this, the culture plate is, okay, if there's a gram negative bacilli, and on culture, we are getting a non-lactose fermenting or a lactose fermenting. So constant communication with the clinicians is very important. And we try to maintain that for the benefit of the patients also. So as ma'am said, turnaround time. So the mean time to positivity is approximately 12 to 24 hours. As a general rule, gram negative bacilli grow a little earlier than gram positive cocci. So for 12 to 24 hours, we need the time to positivity. For most of the organisms, yeast take a longer time to grow. So they might take up to 48 hours to grow. And then we have to subculture them, so which is again 12 hours at least. And for identification, subculture identification, another 12 hours. And the susceptibility pad testing, we get under 12 to 24 hours. So total turnaround time becomes anywhere between 36 to 72 hours, depending also on the systems that are available. So the turnaround time becomes longer, especially in very sick patient, and you need to know the AST or the resistance pattern. So blood culture turnaround time will be around 36 to 72 hours. The advantages here is we get the full organism identification along with the full antimicrobial susceptibility pattern, which is very crucial for targeted therapy of the patient. And it detects viable pathogens. It will not detect something which is already dead or something, because it will grow the organisms that are already present in the blood of the patient. And it is a strong evidence for true bloodstream infections. Now it has limitations also. So the limitations which come especially in a pediatric critical care setup is the TAT is longer. TAT is turnaround time. It is longer. Most of the times we cannot wait for 36 to 72 hours to get to know the exact antimicrobial therapy that has to be started for the patient. So that is where the rapid molecular diagnostics by PCR comes into play. The TAT is longer. There is a low sensitivity of blood culture in patients who have prior antibiotic exposure, or in low volume blood samples, or for fastidious organisms, because they are difficult to grow. And again, when the sample is not collected properly, contamination may occur. So actually the commensals grow much prior to the pathogen. And when there is commensals in the flora, when the sample has not been collected properly, they will not let the true pathogen grow. So a wrong report is sent, that commensal flora is grown when maybe something else, like yeast take very long to grow. And if you have commensals in the sample, they will grow earlier. They will utilize all the nutrients in the media and they will not allow the pathogen to grow. So there is false positives when there is contamination in the sample and in prior antibiotic exposure. So we also tell the patients that, tell the clinicians also that most of the patients who end up in the pediatric ICU would have had antibiotic exposure prior somewhere else in a primary center or in the wards. So what we tell is that when you take the sample, you take the blood culture sample just before the next antibiotic dose that is due, because at that time there's a least antibiotic concentration in the system and there are higher chances of recovery of organisms from the blood culture bottle. So I will just discuss a few very brief cases which will help us understand the importance of blood cultures. So this is a 10-year-old boy with severe pneumonia who was on high flow nasal oxygen, and he was being given ceftriaxone and azithromycin and he was not improving. Blood culture was sent, and after 14 hours the blood culture grew, signals came positive. Gram stain made showed gram negative cocobacilli, and the identification after subcultures done was he was growing Haemophilus influenzae type B. The AST was done and it was sensitive to cefotaxime and resistant to ampicillin. So what this blood culture system helped was, first of all, it cut down the azithromycin as the therapy was changed to cefotaxime. So unwanted antibiotics like azithromycin was not given. And for Haemophilus, cefotaxime is actually better than ceftriaxone, although they are from the same class of antibiotics. So the therapy was changed to cefotaxime and the patient showed rapid clinical improvement. And this is really important in partially immunized child who has not been immunized for Haemophilus. So blood cultures actually help us in detecting unusual but clinically important pathogens which are not covered by empiric therapy. There's another case of a 2-year-old girl with prolonged fever and hepatosplenomegaly, and with the history that was taken and a detailed history, an atypical infection was suspected. So initial tests were sent and the PCR sepsis panel came out to be negative. Chest imaging was normal. The blood culture reports that came out after 48 hours grew Brucella melitensis. So what we have to know, what Brucella is, a very slow growing bacteria. It will actually take 48 to 72 hours to grow properly in a blood culture system also. And this is rare in children because they don't have that much exposure with the live poultry, live animals. So this Brucella melitensis was growing in blood culture system, and which was confirmed with repeat culture and serologies was positive. And the patient was started on rifampicin and cotrimoxazole for 6 weeks and the fever resolved. So what we have to note here is that blood cultures can identify rare and slow growing pathogens that PCR panels do not cover. Actually, in PCR, as ma'am said, there are panels. They don't cover all the organisms. They cover a set of organisms which has been incorporated by the company that the system that have done, which is the most common organisms. But there are still some rare organisms which are not covered in the PCR panels also. So blood culture will detect those organisms also. So coming to the PCR and molecular testing, so the systems that we see here is an automated PCR method for it detects microbial DNA and RNA directly from the blood, and it does not require viable organisms, and it is actually useful when culture is negative and infection is suspected. So we have different types of PCR panels. We have multiplex PCR panel, and like film array biofire systems, we have real-time PCR and we have targeted PCR for specific pathogens also. Like these are also multiplex PCR. So we have targeted PCRs like neonatal sepsis, which have a set of organisms which are implicated in causing sepsis. So we have such targeted PCR panels also. So the indications of PCR and PICU is critically ill children with suspected sepsis, and as I said earlier, antibiotic pre-treated patients and patients with suspected infection with fastidious organisms like Legionella, Neisseria, Hasse groups, which are difficult to grow on conventional cultures, and when viral etiologies are suspected, and CNS infections with systemic involvement. It is very difficult. The recovery of organisms from CNS is very difficult. It's very low. So in CNS infections, PCR are especially very helpful. So the workflow of PCR testing is that we do the blood collection and we do nucleic acid extraction of that. This is further amplified where the DNA and or RNA sequences are targeted, and multiplex panels are used which detect various bacteria, fungi, and even resistant genes are detected. So these results are interpreted by microbiologists and the report is generated. So this turnaround time comes out to be 1 to 2 hours in amplification, and for panel-based systems, it takes max to max 2 to 6 hours. So these are much, much faster than culture. Where the turnaround time in culture was 36 to 72 hours, we can get the same reports results in approximately 2 to 6 hours. Like biofire is very fast, it is 1 to 2 hours. But in biofire, the caveat is that we need a blood culture positive bottle for to put a BCID panel. But while in the same, like in the meningitis panel, we can do directly from CSF. So we get the results in 2 to 3 hours. The advantages of PCR is that it helps us in really rapid detection, which will in effect leads to an early targeted therapy. It has a very high sensitivity, especially in patients who are priorly treated with antibiotics, and it can also detect resistance genes like MEK-A, VAN-A, VAN-B, or KPCs. Like it will not just tell you that this is Staph aureus, it can also tell you that there is MEK-A gene, so it is an MRSA, so you have to give this targeted therapy. And it is significant in low volume samples also because we don't need too much of a sample to put a PCR. There are certain limitations also, like it will detect DNA even from dead organisms. So false positives can also come. And as I said earlier, there's a limited panel coverage, cannot detect all organisms. Like in the case we priorly discussed, Brucella melitensis was not in the panel. And as Dr. Neha said, Burkholderia is also not in the panel. It is expensive. As Dr. Neha discussed, the BioFire panel in BCID will cost around 14,500 to certain centers who even charge 20,000 for the same. And it will not give a phenotypic AST, like it will not give you other options of drugs, like it will just give you the resistance genes. So these are the drugs that can be used. And it has poor performance in polymicrobial infections. Like you cannot tell that like if there are more than one organism causing the infection, the PCR might detect only one or two, and it will be difficult to cover all of them. While culture, all the organisms will grow. And also in certain panels like stool panels or URTI, or well, we have to figure out, it might detect flora also because nucleic acid is present of the flora also. So we have to clinically correlate that which will be a pathogen and which can be a commensal. So coming to the comparison and clinical impact among blood culture and PCRs. So blood culture will detect viable organism while PCR will detect DNA and RNA. So can detect a non-viable organism also. Turnaround time is definitely much lesser for PCR, max to max 6 hours, while in blood culture it will at least take 24 hours even with all the automated systems, and might even go to 70 to 96 hours. Blood culture will give the entire antimicrobial susceptibility testing with MICs, while PCR will give only gene markers. They are an indicator of what resistance is present and what drug can be given, but they do not tell us the exact panel for the exact targeted therapy. And if one drug cannot be given for some particular reason like AKI or some allergy reaction, it doesn't give a whole panel of other drugs that can be used. Cost in blood cultures is moderate while PCR is very expensive, and it is blood cultures is used for routine sepsis evaluation while PCR can be used for rapid diagnosis in critical cases. So it also helps in antimicrobial stewardship also, because it allows us to de-escalate earlier with PCR results. So PCR avoids unnecessary broad spectrum antibiotics that can be given, and targeted therapy can be achieved once AST is available. And it also helps in diagnosis of, which can be contaminant, which can be not. So I will discuss like few cases for the same, just to give a brief idea of how it helps. So this is a case of a 5-year-old boy who was post-operative day 3 after repair of a congenital heart defect. He was on mechanical ventilation and there were fever spikes overnight. Temperature was 39 degrees Celsius, heart rate was 160, BP was 82/50, respiratory rate 32 per minute, ventilator supported, and CRT was 4 seconds. Chest auscultation showed forced crepitation and sternal wound appeared clean. On the lab findings, TLC was raised about 22,000 with neutrophil predominant. CRP was raised 150. Procalcitonin was raised and lactate for 4.5 millimoles per liter. Chest X-ray showed patchy consolidation in right lung field, and microbiology samples were sent. What all was sent was a paired blood culture, endotracheal aspirate, and rapid multiplex blood PCR panel for sepsis pathogen because the patient was critical. So PCR results came within 3 hours. So, and it detected Staphylococcus aureus. Now, as I said, PCR also gives us the resistance gene. So it detected MAC-A genes, which indicates that the Staph aureus was a methicillin resistant Staph aureus. And so we got the report of a methicillin resistant Staph aureus bacteremia sepsis before we got the culture results. So blood culture results came after 24 hours and they were again positive for gram-positive cocci, and final ID AST took 48 hours and which showed MRSA, which was sensitive to vancomycin and linezolid. So what we get to see here that there was early detection of Staphylococcus aureus with MAC-A, which strongly suggests MRSA, and this rapid therapy escalation was very important in a post-operative PICU settings, and it prevented further complications also. So empirical therapy was, which was from ceftriaxone to amikacin, was immediately changed to targeted vancomycin therapy as soon as the PCR results got, and the child stabilized much earlier within 24 hours, and later the therapy could have been modified by AST. Another case of a 9-month-old girl who had high-grade fever for 3 days and was treated with oral amoxicillin at a local clinic. So she came to PICU with lethargy, poor feeding, and tachycardia. Temperature was 38.7, heart rate was 170, and SpO2 was 94% on room air. And on examination, she had a bulging fontanelle, mottling of skin, and there were no focal signs. So TLC was 15,000, CRP was 120, and PCT was 25. And CSF was initially, testings were initially deferred due to the instability. So other microbiology samples were sent, like paired blood cultures and PCR-based panels because patient had already taken antibiotic exposure. So here PCR-based panels become very important. And after the child stabilized, CSF was sent. So the PCR results detected Streptococcus pneumoniae and none of the resistance markers were sent. And blood culture, here this PCR detected Streptococcus pneumoniae, while blood culture did not detect anything because the patient had already taken oral antibiotics earlier, which were because due to prior amoxicillin therapy. And because of that, the growth was suppressed and CSF results were did not grow anything on blood culture. CSF results again, gram stain was negative, and PCR again detected Streptococcus pneumoniae. So this confirms the diagnosis of pneumococcal meningitis with bacteremia. So what we see here is that child was clinically septic but culture negative because of the prior antibiotic that she had taken. And in general, from CSF, the recovery of organisms on culture is very low. And this PCR here allowed early confirmation in the setting of a prior antibiotic exposure, and it enabled targeted therapy and avoided unnecessary escalation. So the patient was started on IV ceftriaxone after the PCR result, and this really actually helped us to avoid the higher antibiotics like vancomycin and meropenem unnecessarily. And if we would have relied only on blood culture, it would have delayed the diagnosis by more than 48 hours, while here the child actually improved clinically within 48 hours itself. So this has really helped us and with the early diagnosis and treatment of the patients. So ideally, there should be a combined and integrated approach using blood culture and PCR both, because PCR actually aids early therapy while blood culture confirms and provides AST. So blood culture is the gold standard for a reason because it detects viable organisms and it gives us the proper AST. So, but best outcomes are achieved when both the methods are used complementarily. The algorithm for diagnosis in PICU is collect blood culture before antibiotics. So even if the patient has taken prior antibiotics, the blood culture should be taken just before the next dose of antibiotics. Start the empiric therapy after sending the cultures. And if the patient is very critically ill, send PCR panel, de-escalate the antibiotics based on the PCR panel, and final adjustment and targeted therapy has to be based on culture and AST. In future, we can actually look for fully automated rapid blood culture systems with PCR hybrid platforms. And at present, all we talk about is AI. So AI-based interpretation also helps. And as ma'am had earlier said, Dr. Neha had earlier said, there are a lot of viruses which are not covered in the panels right now. So we have a lot of panels. We have BCID panel, we have prosthetic joint infection panel, we have neonatal sepsis panel, then upper respiratory tract, lower respiratory tract, meningoencephalitis. So even in multiplex PCRs, which are not automated, there are panels like bacterial meningitis, viral meningitis. So we have a lot of panels, and Biomiro is a company which brings out a lot of these biofire assays. So they are actually coming up with a tropical fever panel also, which will have dengue, leptospira, and everything. So that will also be very helpful in the future. And this will actually help us with point of care molecular diagnostics also. So in the end, to summarize, I'll say that blood culture is the gold standard, but it is slow. PCR is very rapid, but limited in its scope of organisms that are in the panel. The combination of blood culture and PCR really improves the early diagnosis and outcomes, and it is a very essential tool in modern pediatric ICU sepsis management. So, rapid answers start the journey, but definitive culture results complete it. So in critical care, both are essential to save lives. Thank you. For
Thank you, Dr. Prerna. It was very nice. Can you stop sharing the screen?
Yes, sir.
Uh, I think so. There'll be a lot of discussion. So before we go for the question and answer session, I'll ask Dr. Dhanya to give few comments and pointers for making it more clear and clean for the learners.
Thank you very much, Dr. Maninder Singh. Thank you for this opportunity. There are few points that I would like to highlight from pediatric perspective. So after two excellent presentations, so I'll just first go by the first presentation. So the first case of NTS salmonella, basically when a child comes in a septic shock or a shock-like situation, the ground reality is that there is, I mean, I'm sure Dr. Manda will also agree that there is so much panic among parents that, you know, you have to stabilize the patient first, and also like you have to take the basic history, but sometimes it's not possible to have a detailed history immediately. So while history is, I mean, it definitely history and physical examination will guide you, but it's always important that when the initial IV is put, please take blood cultures and then take extra samples. And after stabilizing, after the basic history, then you can go into detailed history. It could be any food consumption, it could be mushroom poisoning. So all this is important, but I mean, how you're going to manage depends on the other factors also. So that is one comment. Secondly, in pediatric, generally, NTS salmonella is self-limited. It just presents as diarrhea. So as a strong recommendation in pediatric patients, if you have NTS salmonella bacteremia, it becomes important then to investigate for immune deficiency. So that's the difference between, I mean, for a pediatric, because generally you don't see NTS bacteremia in a immune competent child. It's either a malnourished or a diabetic or an immune compromised. So your management doesn't end there, just treatment. Then the other thing about blood cultures, see, blood cultures, there is a lot of controversy even today regarding the sets. Western countries and adult, they talk about sending aerobic and anaerobic. But the anaerobic bacteremia is very rare in pediatric population. So what is suggested by many ID physicians, even in India, is pediatric, talking is, if the blood volume is limited, at least send 2 aerobic blood culture. Then there is controversial about preparation. The iodine is sort of given up in many centers. I don't know if any of the panelists will agree, because of the high contamination rate that we get with iodine. So most of the centers, including mine, we use only chlorhexidine for that purpose. But of course, the proper sterilization of the skin is important. Then coming to PCRs, I mean, both the panelists have excellently covered the issue of viruses beyond the common infections. So what is also important is epidemiology. For example, we had recently 1 year back a huge adenovirus outbreak. We had influenza outbreak. So there are two types of PCR, targeted and multiple. So sometimes you don't need to really go for the entire panel. If there is a flu outbreak, even like if your institution has in-house, you can go for a flu PCR. So epidemiology is important when it looks like adenovirus, just an adenovirus PCR, because ultimately the cost also matters. The cost of sending, and whatever you send, you have to think, just like we say, think before you ink an antibiotic. Diagnostic stewardship, you have to really think whether it is required. GI panel PCR costs around 20,000 already. Everything is going to cost a lot. So think about that. So one thing I would suggest is, like, for example, BioFire or CNS panel, for example, will not cover the mumps or measles. These are more common than KFD. So what I would suggest is that you keep an extra sample, because these tests are covered by the government NIV centers. So what we do is, if this comes negative and you're still wanting to know whether it is JAP encephalitis, you send one sample to a nearest NIV center. So they will look out for these ones which are not covered. So remember that. Regarding storage of the cultures, transport, somebody was asking the question, answer chat. Easy to remember is, from the sterile sites, do not refrigerate. So blood culture, CSF, do not refrigerate for culture if it is from a sterile site. So what about blood, CSF, body fluids? If it is from an unsterile, such as urine, stool, then you have to refrigerate. So that is easy way to remember. And then lastly, I think now there are companies that will come to you with next generation sequencing. I think that was not covered in both the talks, because that's already the medical representatives have started visiting. Next generation sequencing, they will say that we can check for anything on the earth type of they will present. So beware of that, because NTS also, it's like finding a needle in the haystack. So ultimately, all the basic things like history, clinical examination, what's your provisional diagnosis, all that matters. But regarding the NTS, it is at present only recommended if you know the focus of infection. Say it's a brain abscess, and it may have some organisms beyond what can be picked up on the culture, or or standard PCRs. Something unusual, you know the focus, or you have run everything, all the standard ways to investigate, and still the patient is having fever, and it's very unusual. And then lastly, what happens is, as I told you, epidemiology matters. Now, you know about the outbreak that we had in Kerala, amoebic meningoencephalitis. So what is happening around is also important. So there, the government has made it compulsory to do wet mount. That's a simple test. Wet mount in all patients with who's presenting with encephalitis, so that this is picked up as early as possible. So these simple things, epidemiology, and going, even like if we had in the influenza outbreak, we had children presenting with flu encephalitis. So how did we pick up? We picked up by the nasal swab. So these things also matter beyond what has already been nicely discussed by the speakers. Thanks.
Perfect, perfect. Very clear and clean messages, Dr. Zanya, because I know that it can be very dirty sometimes when you're discussing antibiotics and blood culture. So over to Dr. Indira. Ma'am, what are your takes as far as the intensivists are concerned, and what more would you like to tell or delete something?
Thank you. Thank you for the fantastic presentation, Dr. Neha and Dr. Prerna. You emphasized the importance of not only blood cultures, the importance of blood cultures and how it can change the whole perspective and the syndrome. You brought out there was so much emphasis on look, listen, and feel your patient, right? And I think Dr. Dhania has also emphasized look and listen to what's going around you. What is the community outbreak? So because that also brings a perspective when you have your patient in front of you. Involve experts. And I think there are some questions, is blood culture versus PCR? For bacterial infections, blood cultures, without it, it's like shooting in the dark. You do need blood cultures. The more, the better. And in pediatrics, we have the green and orange. Now, our ID always says do collect in anaerobic as well, because sometimes we have seen our Enterobacteriaceae, your E. coli, Klebsiella, growing faster in the anaerobic. So because they are facultative anaerobes or whatever, but sometimes they grow faster in the anaerobic. So we collect 2 sets, 3 would be very ideal. Another thing about blood culture bottles, if you're collecting sample from any other sterile site, pleura, peritoneal blood cultures, we also instill them into the blood culture bottles for faster yield, sometimes even from the EVD. Storage already been mentioned. Now, PCR is more for viruses. Of course, if you want rapid, bacterial identification, that is great, but that's a luxury. So don't go without blood cultures. It's not blood cultures versus PCR. You do need your blood cultures. Viruses, PCR definitely is very helpful. But remember, dead viruses also, you can have a positive PCR. So everything has to be in the clinical context. So don't just, treat COVID if the patient is very stable because you have a COVID PCR positive. And as Dr. Dhania mentioned, to reduce cost, so the treatable viruses or viruses that are going to make a difference, like we have only Trivus package. So for an immune compromise, we use only COVID, RSV, as well as influenza. Now, these are the only treatable viruses that will make a difference because you have to treat, have specific treatments for these. You don't need to spend money for the entire battery array of viruses and waste the patient's money. So that is something that you have to bear in mind. And so excellent take-home points, and thank you so much, Dr. Prerna and Neha, and Dr. Maninder and Dr. Shyam for this wonderful initiative. It's so important for all DNB fellows, even consultants. All of us keep our learning to know and get the basics right. So thank you so much for this opportunity.
Thank you, ma'am. Dr. Dhania, there's a question regarding the break point. So it was not discussed in interpretation of blood culture point interpretation. So can you tell me in just 4 lines the importance of break point versus MIC?
I think the microbiologist is better to answer this question. But breakpoints are very important to, in fact, look at a group of antibiotics, a class of antibiotics, and discuss which one is better, which is farther from the MIC. I mean, you can explain it better, I think, Dr. Prerna. I'm sorry, because the microbiologists are better in explaining what are breakpoints.
So just by understanding breakpoint MIC, so breakpoints are defined for different set of antibiotics by the society. You have UK class. So they tell you for colistin, this is the breakpoint. Above this, it will be resistant, and below this, it is sensitive. This is set by the governing body, antibiotic bodies across in UK, US, etc. Now, when we do MIC, we test it for the bug, the culture that is growing with us, what sensitivity this bacteria has for the particular antibiotic. And so what is the MIC of the growth? So is the MIC, and we compare it with the breakpoints. So that is, the breakpoint is a general set of data specific for each antibiotic, whereas the MIC, we are checking for the growth, the culture that we have with us. comparing it to the breakpoint to say whether it is intermediate resistant, or it is sensitive.
I agree, ma'am. So a breakpoint will be given to you only once you ask a microbiologist to share it. Otherwise, some of the reports will not share the breakpoint. So you have to ask sometimes to get it. Other questions I am seeing, they are very general questions. Everything has been answered by the panelists in their talk only. So just one brief question, Dr. Indira, about the panels. Is there any specific way you decide that you have to send an upper respiratory panel or a lower respiratory panel? In which condition you would prefer to send which one? I think that's what they're asking, the syndromic approach to the patients.
So, as all the speakers and Dr. Danya also mentioned, it is very, very important to first understand what are we dealing with. So, right from your history, your clinical examination, then your the community, what's happening. So, you have to that, and then rather than shooting in the dark, you decide what is needed, which is cost effective for your patient. So, if you have a patient with neurological problems, then it has to be. Definitely, you will not be sending the entire lower respiratory, upper respiratory.
Right.
You would be sending for your CSF and your viral studies. It will be also, as ma'am mentioned, it will be easier, cheaper if you send it to some lab which does Japanese encephalitis, because that, though there's no particular treatment, you at least know what is going on with the patient. So it has to be a syndromic approach. The clinical is the most important, and then it is supported by additional diagnostic tests, your imaging and the others. So that is my take. And if it's not going to make a difference to your management, please don't send unnecessary tests.
True, very true, ma'am. This is the most important point, I think. So unnecessary sending that reports and then banging what to do with the reports. Over to Pankaj, sir.
Yeah, this discussion is very, very important for all of us, whether we are pediatric intensivist or neonatal intensivist or pediatricians. Ultimately, infections is the biggest spoil point in our management these days. So I have one comment and one question. Comment is that a lot of drug sensitivity to different bugs come in pediatric and neonatal age group to drugs which are as such not licensed or they are not approved for uses in that age group. For example, we have been talking about minocycline, doxycycline. They come sensitive, like the synergy comes sensitive, which is astronam, avibactam. So if you look at the literature of individual drugs, many of them are not approved for uses in that age group. But we are cornered. We have to use it because there is no other sensitive drugs uses. So my question, my comment is that we should take a detailed consent from the parents, understanding, make them understand that this is something which is unavoidable, but on the current law or current indication or approval of that drug is not there, but we have to use it because of these reasons. Take it a consent from that patient at that point, because ultimately it becomes a medical legal use of a drug in an age group which it's not approved. And the question from my side is that we just listened from Dr. Neha a new drug which is astronam avibactam combination. We have been using a synergy which is ceftazidime, avibactam and astronam. So how the two differ from each other? Like in synergy, we are using ceftazidime with avibactam and astronam. And she discussed that astronam avibactam appears to be another drug which is now available and can be used. So how do the action of two drugs differ? Which one should be preferred if it is coming sensitive to astronam?
I'll give it to Dr. Dhanya to answer, starting with the consent, and the second would be the antibiotic.
Astrodome avibactam, we have been using the ceftazidime avibactam combination. So far, we have not availed of that combination. I don't know about Dr. Indira. Do you get this combination?
No, doctor.
Aninder, have you? I mean, at least in our center, we have not. But as new novel novel beta-lactam inhibitors, there are few which may come in the market. So I think for now the message is use the combination that which is available, ceftazidime, avibactam, and astronam combination. When it comes in the market, aztreonam would help in overcoming NDM sort of bugs. But for now, I think the message, because I don't see the availability, that's the reason.
Yeah, agreed. I think so. Ceftazidime, avibactam, aztreonam for NDM is a take-home point. There's no doubt about it. And regarding the consent for starting these antibiotics, especially minocycline and tigecycline, I think it's a very valid point. We have not thought it from a PICU perspective, but we really don't know after 10 years which law might come and might question us. I've seen with the ROP, it's being a very bad scenario and sad. So I think so it's a very valid point. What about you, Indra ma'am? Because you use a lot of these unapproved antibiotics.
Yeah, so because I deal with immune compromise, and by then they are, colonized with all bad bugs. So we have used occasionally, but I think the key here for everybody here, for all the listeners, the key is getting your blood cultures right, getting the antibiotics right. Because if we just shoot in the dark, we are going, and also invest in a good lab, microbiology lab, coordinate with your microbiologist and your ID. There is no fight, Maninder. We love our ID and microbiologists because we can't do without them. If we don't get that right and we indiscriminately use broad spectrum antibiotics, we are going to breed more resistance. We are going to be requiring more of these, whatever things which are not approved for pediatrics, etc. We're going to be using minocycline, Cepran. Cepran has already made a comeback for Stenotrophmonas. It is very, very scary. And after that, there are going to be no antibiotics in the shelf as well. So I think getting the basics right, getting the syndrome right, use the right antibiotic for the right period of time, and then de-escalate after you get your culture. All that is very, very important so that we don't need higher and higher antibiotics.
Perfect. So I'll just take one line from Dr. Prerna and then we'll close the session. You have been silent for quite a long time.
It was an excellent talk.
Thank you, ma'am. Thank you, sir. I had some network technical issues in between. So I would like to, I don't know, like about, there was a question about breakpoint and MICs, and there's a question of BMQ also in it, among the question answer sessions.
Just
So
very briefly, 1 minute only.
1 minute only. So breakpoints, actually, there are guidelines which have given breakpoints for susceptibility drugs. Like what we have to remember is, if we get a report and we say the MIC of one drug is 12 while the MIC of the other is 4, it is not necessary that the drug with the lower MIC will only work. It depends on the breakpoints that are available for the drug. If the breakpoint for the drug with MIC 4, the resistance breakpoint is 4, and the breakpoint for the drug with MIC 12, the resistance breakpoint is 32. Actually, the MIC with 12 will work better because it is much lower than the resistance breakpoint. So that is one thing we have to take, we have to consider. And BMQ is something in which the MIC of the drug available is the breakpoints is divided by the MIC of the drug that has grown. So higher the BMQ, better chances of the drug working. That is a general rule. Higher the BMQ, the drug will work better.
But it also depends on dynamics and kinetics.
Yes, on the PKPD of the drug, definitely. But if all that considered, just when considering MIC and BMQ, BMQ is a very good indicator, but sadly, very few labs give BMQ. Very, very few labs give the breakpoints also and the MIC also. So
Thank you, Dr. Prerna. Over to Dr. Dhanya, one last liner.
Yeah, I just wanted to additionally comment that regarding the clinical breakpoints, it's not easy to just say if in this group itself, if an example can be given, then I'm happy to do that with the culture report, because it's
We'll
little
do it next
so I'll
time.
do it in the
Okay,
group.
you'll do it then next. Oh, in the
I
group.
mean, in the WhatsApp group, I'm saying.
In the WhatsApp group. Sure, definitely. Dr. Indira, one last take-home point.
I think clinical, getting the cultures, take enough samples of blood cultures. Don't skimp it. If the patient can't afford, there was a question in the chance box. What if the patient cannot afford? Your patient is going to spend much more money staying in the ICU because you didn't get the blood cultures right. You'll end up giving unnecessary antibiotics. The child is going to get more sicker. So I think getting the blood culture right, taking 2 sets, that means anaerobic, 2 sets of these will make a lot of difference. And in the long run, you'll actually save more money. because you got your diagnosis right.
And 2 sets means 4 bottles mean
Four bottles.
lot of blood volume. We are very, very miser, ma'am. We are very
No,
considerate.
you're generous with unnecessary antibiotics, but we are miserly with the blood culture volume. So I think
got it. I got it.
change that. I know you're trying to drive home the point, Maninder.
Thank
Yeah.
you, ma'am. Thank you. I'll ask Dr. Sham, Secretary IIP Delhi, to please close the session.
Thank you, Maninder. Thanks a lot for wonderful informative talk by Dr. Neha and Dr. Prerna. Definitely, after her this talk, our resident practitioner get the lot of the benefit and might be the implement in the day-to-day practice. And thanks to Dr. Dhanya and Dr. Indra to make the concise key points. That is very important thing. And from my side, that is one message. Don't treat the report, clinically correlate the all things. That is very important things. Many times I've got the information in my round, my radiant says, Ki, sir, I got the culture, this one is that. Patient is already very well responded to other things. So before upgrading or de-escalating antibiotic, please correlate clinically. That is a message. Okay. Thanks a lot. Thanks to Dr. Vinay and Dr. Maninder.
Thank you. Thank you, everybody.
Thank you, everybody. It was a great session, and it will be
Thank
available
you.
on the site for review also, so you can see it again and again. Thank you.
Thank you, sir. Thank you.